Thank you for joining the Epilepsy Foundation of Minnesota's Seizure Smart training. In this training, we will define epilepsy and seizures. We'll identify the most common type of seizures, specifically looking at 4 different types, and then we will provide information on how to appropriately respond to each of these seizure types. We will also briefly cover treatment options, impact on life, and specific information for bus drivers in the school setting, what to watch for with your students that have epilepsy. Let's start off by talking about the facts about epilepsy. What do we know to be true and what do we know to be false? Well, first, we know epilepsy is not contagious. We present information to the entire age span from about 3 years old all the way through till the aging population. And what we know is that in particular, certain groups might not know that this is not a condition that you can catch, especially in the young ages. And so we know that it is a medical condition that is specific to an individual's brain activity, so that it is not contagious. We also know that epilepsy is not a mental illness. And let me tell you a little bit more about this. Epilepsy is a physical disorder of the brain, which is caused by reoccurring seizures. Mental health and mental illness conditions are diagnosed. They are occurring in the brain, but they're diagnosed differently through doctors such as psychologists, psychiatrists, counselors. Epilepsy tends to be diagnosed by a primary care physician, a neurologist, or an epileptologist. What we do know is that those who are diagnosed with epilepsy, at some point following their diagnosis, about 50 to 60% of them will also be diagnosed with a mental health condition. We'll talk about those reasons towards the end of our presentation. So they are what we call comorbid or co-occurring disorders, but they are not the same. Epilepsy exists on a spectrum. What is a spectrum disorder? It means that for epilepsy, it means that each person's epilepsy is individual to their experience and to their seizure control and to the types of seizures they have. So let me give you an example. I have several clients I work with who have one seizure type. They take one medication once a day or twice a day. They drive, they work, they go about their life, and the real impact of their diagnosis comes in that one medication they take every day. That's one end of the spectrum. If you were to go to the exact opposites of the spectrum, you would find that we have clients we serve where they take maybe 3 or 4 medications, they have multiple types of seizures, they've tried other treatment options such as surgeries, diets, devices, and they still do not have control of their seizures. And so their experience is much different than those who are on the opposite end of the spectrum. So it's really about the individual person's diagnosis and impact on their life. We also know that people rarely die from having a seizure. There are reasons that individuals with epilepsy do die from having a seizure, one being SUDEP or sudden unexpected death in epilepsy. They might die related to an accident. There's many different reasons that the person could die from having a seizure, but we do know it's rare. About 1 in 1,000 people with epilepsy will die from something related to that diagnosis. So let's move on and talk about what epilepsy is. So epilepsy is a medical condition. It's neurologically based in the brain, and it is characterized by a person having reoccurring seizures. And so what are we talking about? Let's say a person has one seizure, they go into the doctor or they go into the emergency room. Typically, and they will not be diagnosed with epilepsy at that first seizure, because we know that in order to be diagnosed, you either have to have more than one seizure, reoccurrence happening, or there are certain conditions that have epilepsy as a component. So let's say a person is diagnosed, for example, with tuberous sclerosis. That diagnosis contains many different parts to it, one of it being seizures. And so that person who has a tuberous sclerosis diagnosis, if they have a seizure, they might also then be diagnosed on that first occasion with epilepsy. But for the most part, people are diagnosed with epilepsy after having reoccurring seizures that are unprovoked or not due to something else that is non-neurological based. It's also called a seizure disorder or a condition. So epilepsy is a neurological medical condition. It occurs very frequently. As you look at our diagram here in our graphics, you'll see 65 million people in the world 3.4 million people in the United States, about 60,000 people in Minnesota and eastern North Dakota. Or if you like to look at that 1 in statistic, we know that 1 in 26 people will be diagnosed with epilepsy at some point in their lifetime. For children under the age of 18, it is the #1 neurological diagnosis for them. And so we know that it is an important thing to train people on what this is and how to respond to it, particularly those who are working in specific age groups like children in school systems. Let's move on to talking about a seizure. So epilepsy is defined as that neurological medical condition characterized by recurring seizures. Well, what then is a seizure? A seizure is a single medical event where, as you can see in the brain, there's lots of different lobes that are responsible for different functioning for the person. If you think of your brain as the main computer where it tells your body everything it should do, and it does that through neurons or brain cells. And those brain cells or neurons travel across pathways to communicate with one another and then to the rest of the body. Well, when a seizure occurs, it's a single event where there's misfiring of those neurons in the brain. So the neurons are trying to get the message across the pathways, and for some reason they misfire. You can think of it as like a storm in your brain, electrical shock in your brain, different ways to kind of picture that it's that misfiring. Depending on which of these lobes the seizures are occurring in, the seizures might look different and they might impact the person differently. So if you have a seizure that's coming in, for instance, from the lobe of your brain that's responsible for movement, you might see some different movements. If it's coming from the lobe that's responsible for vision, you might have visual disturbance. So we know that there's lots of different ways that seizures can manifest themselves, and sometimes it does have to do with the lobe of the brain. So we've talked about what the diagnosis of epilepsy means. We've talked about what a seizure is. Now let's move into talking a little bit about why is somebody diagnosed with epilepsy? What are those causes that we know of that lead to the reoccurrence of seizures for an individual? Well, epilepsy has several different reasons that there are causes. And I'd like to start by talking about the physical sort of reasons. And so if you think of the brain and what a physical structure of a brain typically looks like, and then think about things that can happen to that physical structure that change it, things like stroke, where part of the brain has died, injury to the brain that has caused bleeding or swelling. There might be parts of the brain that never developed correctly, and so they're atrophied or they are shrunk smaller than the rest of the brain. There might be someone who has a tumor growing, and so there's more tissue on the brain that has changed what that typical brain would look like. Why are those all potential causes? Because when you think of the brain and how those neurons are traveling across the pathways, anything that changes what that looks like typically could lead to misfiring more likely than other things. So we're looking at head injuries, we're looking at tumors, those kinds of things, and brain development in young babies. So those are some of the main physical reasons that someone might have reoccurring seizures and that epilepsy diagnosis. Some of the other reasons are infections. Two main brain or neurological infections are encephalitis and meningitis. So those can occur, cause reoccurring seizures, be treated, and actually, the infection is treated and resolved, but the brain may continue to misfire, but the origin was from that infection. We also know that there are genetic reasons, and so there might be a few different epilepsy syndromes that do have a hereditary component, but they're quite rare where a parent would pass something to a child. But we also know there's another genetic component that is about actual DNA level mutations and deletions. And so on a chromosome or on a strand of DNA, there's something that happens at conception where there's a deletion or there's a mutation, and there are certain epilepsy syndromes that actually are derived from those mutations and deletions. And there are seizures that occur and look similar in those syndromes, but the origin comes from genetics. So these are all causes for epilepsy, but the bottom circle there says unknown in many cases. It should probably be our biggest circle, because what we know is that 70% of people with epilepsy do not know why they have it. So they don't have a cause they can look to as to why they are having reoccurring seizures. And that's a high statistic. And we know that because our brains are so unique and individual, that there tends to be times where our technology, our brain imaging is not sophisticated enough quite yet to actually pinpoint if there's an actual cause. So there's also a lot of times where the diagnosis can be misdiagnosed, and so it takes some time before the person is diagnosed correctly because they think it's something else. And so it might take some time to figure out what is the cause, and those people would fall into the unknown until there's a definitive reason. But 70% are unknown. Triggers. So we're going to talk a little bit now about what are the reasons that a person with epilepsy might have what we call a breakthrough seizure. There are triggers in our environment, in our lifestyle, in our world for people with epilepsy that could lead them to have breakthrough seizure, whether it's that they've been controlled for months or years and then they have a breakthrough seizure, or they've been controlled for a week and they have a breakthrough seizure. And so as we talk through triggers can be important because some of them are environmental, and sometimes there can be situations where a trigger could potentially be removed and taken away from that environment, thus reducing the risk of the breakthrough seizure for the individual. So the first and foremost, one of the biggest reasons for or triggers for breakthrough seizures is missed or late medication. We have individuals who take their meds on a very scheduled time frame because they know that their med in their blood, the level of their med in their blood is really critical to keeping them under control. So if they missed a medication, or they've even become late on taking a medication by a few hours, that can trigger some breakthrough seizures. If we ask the general group and population of people with epilepsy, what is a trigger that you have? Most of them would say in some shape or form, stress. And stress is a really ambiguous word. It means very different things to different people. And so when we talk with people about stress being a trigger, we want them to look at what is it about the stress? What kind of stress are you experiencing? Are there certain types of stress in your life that are triggers versus other types? And so we ask them to look at what are the stressors that you would align with your breakthroughs, and what can you do to reduce that stress? How do you handle that stress? And a lot of times as individuals are working with their doctors, they're talking about ways, sort of mechanisms to reduce their stress levels. Lack of sleep, hormonal changes. So if you are a school bus driver and you have kids on your bus that are going through puberty and they have epilepsy, sometimes those can be the biggest times of breakthrough seizures for that age group because of the fluctuation of their hormones. It impacts the metabolism of the meds for many people. We also know that use of alcohol or drugs and interactions with other drugs. And so one of the things that people with epilepsy have to be aware of is that when they're taking a medication and then they take an over-the-counter, let's just say a vitamin or a cold medicine, to make sure that they're talking to their pharmacist and not taking something that could potentially interact negatively with their medications for their seizures. Overheating and dehydration are big triggers, poor diet or missed meals. And then there is this other trigger called photosensitivity that many people know about, that many people have heard about, because it is a trigger that is actually tested during an EEG study for the person with epilepsy. So photosensitivity is that flashing lights sensitivity. And so when you think about our environment, we aren't talking that we are always in front of strobe lights or very obvious flashing lights, but there's other lights that flash that can be triggers for individuals with epilepsy. In particular, thinking of fluorescent lighting, if those light bulbs go out and flicker, that could be a potential. And we know that sometimes in this great Midwest that we live in the wintertime, sometimes the sunlight through the trees can create a flashing light sensation. I did have a client who, he was riding the school bus, very relevant story, and he was sitting on the inside watching out the window, and the sunlight through the trees triggered him into a seizure. And so he realized, his family then realized that he did have that flashing light sensitivity. We also know that there are very minor photosensitivity situations like computers and their what's called flicker rate, or in school systems, the fire alarm systems that are flashing lights. And so what we want people to know is if you have a flashing light sensitivity, to be aware of that. And then in situations where you can avoid the flashing lights, let's say it's a fire drill and the student has flashing light sensitivity, being aware of that and getting that student out before the fire drill starts would be a great option. But one of the things, I tell you all of that about flashing lights, but I want to make it clear that this is really a minor trigger, meaning low occurrence, not minor, but low occurrence rate. So about 3% of the population with epilepsy has a photosensitivity trigger. But it is there, it does happen, and there are ways to avoid that particular trigger. We're going to pause now and just review what we talked about. So we've talked about defining epilepsy. We've talked about defining seizures. So epilepsy is the medical condition. Seizures are the single medical events that occur in epilepsy. We know there are many causes for epilepsy, including physical, brain structure causes, infection causes, but that most people, about 70%, do not know why they have epilepsy or reoccurring seizures. And then we also know that there are several triggers that potentially could lead to breakthrough seizures for individuals. One thing with that triggers that I did want to, I'm going to go back here and just mention is this is not a comprehensive list. It is a list of the most common triggers, but each, again, person with epilepsy has an individualized disorder, so their triggers might be different from anybody else, and it might include something that's not listed here. So we're going to move right now into talking about types of seizures and how they're classified. And so as you look at this diagram, you see that there's, it's a really nicely put together diagram, but we start at the top where there's this new classification of seizures. So if you have ever been trained or ever known someone to have seizures or heard anyone speak about seizures in the past, you might have heard different terminology. Many years ago, the common terminology was grand mal and petit mal. And then in the late 80s, the terminology changed to generalized and partial. And then in 2017, the International League Against Epilepsy realized that they were not still encompassing all of the types of seizures into these buckets, these larger classifications. And so they changed the main classifications to focal, generalized, and unknown onset. When we talk about a focal seizure, we're talking about there is a focus in the brain. There's a focal point where the seizures are coming from, and the person's seizures are actually located in that one spot. When we move over to generalized onset, we know that generalized onset seizures occur across the entire brain, and so the whole brain is involved and will look very different than a focal onset seizure, in most cases. And then in the unknown onset bucket, we know that there is oftentimes when a person has unknown onset, it is in the beginning of their diagnosis where they haven't been able to determine, are these actual focal seizures, are they actually occurring across their whole brain? So sometimes in that very beginning phase of being diagnosed, the doctor or the physician will say to that we do not know the onset yet. So you are in that unknown onset category. We're going to break it down and talk about two focal types of seizures and two generalized types of seizures next. A lot of words on this screen, but let me just say that the two types of focal seizures are focal aware and focal impaired aware. Focal aware seizures, as we move into talking about them, used to be known as a simple partial seizure. And it's a seizure where there's a change in sensation for the person typically, but they don't lose any level of consciousness. And so typically this would be somebody who is just going about their business, doing regular normal activities, and suddenly they get that sensation that is odd and different from what anyone else is experiencing. It is unique unto them, and it happens. And when it occurs, it's the same sensation each time. So examples could be, they suddenly get really warm, or they get really cold, or they suddenly see something or smell something. And those sensations typically tend to be the same each time the seizure happens. And they might be able to verbalize, I think I'm having one of my seizures. I smell burning rubber really strongly in this room, where no one else in the room is experiencing that sensation, but they are, and they know that that happens each time they have this type of seizure. So how do you respond to the focal aware seizures? Well, a couple of things. You might not ever know they're happening unless the student or the person you're with says that they are having one. But if you are responding to this type of seizure, it's really reassurance and emotional support. They haven't lost consciousness. And so for them, it's really just about making sure they know they're okay and then documenting. If you are in a position where you have to document things like behaviors and medical events and things like that, you want to document that and let the parent, in the case of a child, the parent or guardian know, or give that documentation to the person who has epilepsy so that they can then let their doctor know that they have experienced an increase in their focal aware seizures. We're going to move to our most common type of seizure called the focal impaired aware seizure. And again, remember these two seizure types, the one that we just discussed and this one, are coming from a focus point in the brain. They used to be called partial because we thought that, there's part of their brain that's seizing. Well, in focal just means there's a focus point, and in this type of seizure, there's an impaired level of awareness. So I'm going to show you a clip, but let me first explain a lot of things that might happen during this seizure. It is the most common type. And oftentimes what happens is the person will be functioning normally, and all of a sudden it's almost like a switch goes off and they start to do some purposeless movements. They mumble and don't make any sense. They appear glazed over or aren't responding normally, but they're doing some unusual movements that have no meaning. And it's unusual. They might stand up and begin to wander, for instance. They might pick at their clothing. Their lips might smack. Their eyes might flutter. They might talk and get their words mixed up, or it all be non-words, like garbled language. And keep in mind that they are conscious, obviously, because they have their senses about them, but they're unaware at the level where they can respond appropriately. So I'm going to show you a clip, and then I'm going to talk through it and point out a few things the second time around.
The complex partial seizure usually starts with a blank stare. The child may experience a loss of awareness and will exhibit automatic behavior known as autonomisms, such as a chewing motion or picking at their clothing. The preschooler having a complex partial seizure may seem dazed and may mumble. Sometimes the child's behavior may be mistaken for disorderly conduct.
So I'm going to show that to you one more time. I want you to watch in the very beginning of this clip for his eyes and his mouth. It's really subtle. Then you'll see the picking motion, and then you'll also see that the responder is actually talking to him, and you'll see him turn towards her. And so they can hear their name. They have their senses, but they're not going to respond appropriately. So let me show you one more time and watch for those eyes and mouth, and then the picking motion.
The complex partial seizure usually starts with a blank stare. The child may experience a loss of awareness and will exhibit automatic behavior known as autonomisms, such as a chewing motion or picking at their clothing. The preschooler having a complex partial seizure may seem dazed and may mumble. Sometimes the child's behavior may be mistaken for disorderly conduct.
So what do you do in that situation? Well, first I want to say in that clip you saw the woman responding, kind of had a hold of his arm. That is not what we would recommend doing. And I say that because in that situation, she knew him and knew his responses, I'm imagining. And so why do you not want to restrain them or give them any sense of being restrained? Because what happens in that type of seizure is because they're at an impaired level of awareness, they are what we call in fight or flight mode. And so depending on the situation, depending on their individual seizure type, them being touched or you coming forward at them, it can be seen by them in their level of awareness as an aggressive behavior towards them or as a risk to them. And so what they do is go into fight or flight, where they might hit, they might kick, pull hair, things like that, because really all they're trying to do is keep their body safe. They sense danger coming at them and they want to respond. Keeping in mind during this time their brain is seizing, so they have those unusual movements, those unusual maybe sounds that they're making, and they're also trying to defend themselves because they're in fight or flight mode. So you really want to stay calm and not restrain them. You want to gently guide them away from hazards, meaning if you walk alongside them and they're heading towards a street corner or downstairs, if you provide the barrier between them and that hazard, and walk quietly and gently beside them, they will avoid that and they will take that path of least resistance. The key thing is you want to track time. Tracking time is important with all seizure types because there is a level or a time frame that if we hit 5 minutes in any of seizure types, it does require, or the best practice is to call 911. And we'll talk a little bit more about that specifically after the next two seizure types, but track the time. When did this start? When did it stop? And how do you know that this isn't just a behavior? Because sometimes these can look like behavioral concerns. Well, keep in mind that a seizure is a single event, right? We talked about that. It starts, there's unusual behavior, and it stops within seconds to a few minutes. And when a person comes out of the focal impaired aware seizure, many times they're confused as to where they are or what they did. And there's a sense of that they know that something's happened, but they don't know what. And so they might be frightened, they might be confused, but it's a finite event that happens, right? And so unlike some behaviors or some other circumstances a person could be in, such as intoxication, that can go on for a longer period of time than a few minutes. And for a seizure, it starts and stops and is a finite event. So that is the focal impaired aware seizure. Moving into generalized seizures, remember we talked about generalized being across their whole brain. So as you look at this brain, it means both hemispheres of the brain are seizing. There could be multiple lobes involved. Typically there would be, and there's a loss of consciousness. It might be very brief loss of consciousness, or it might be a prolonged loss of consciousness. And so there's many seizure types. We know that there are over 40 types of seizures. We focus on the 4 most common types because those are typically the ones that most people would know how to respond to or would see someone experience. And so as you look at this list, we are going to talk about absence and tonic-clonic, but know that these other seizure types do exist. Atonic seizures, just a small note on them. Oftentimes, if you think of atonic, it means loss of muscle tone. And so it's just a sudden sort of loss of all muscle tone, and they hit the floor or they go down. Oftentimes, this type will be wearing a helmet still because of their potential for injury. Sometimes with generalized tonic-clonic as well, but atonic seizures can have they can be called drop attacks, excuse me. So sometimes an individual might wear a soft-sided helmet for the head safety. But we are going to focus on absence and tonic-clonic. An absence seizure used to be called a petit mal. Absence, it kind of is what it sounds like. It's like an absence of the person. It's a staring. It can be seen as a staring spell, a daydreaming moment, those kinds of things where the person is fully engaged. Suddenly they stop and stare off, usually to one side. They might move their mouth a little bit or flutter their eyes a little bit, and then they come right back to awareness and continue on with what they're doing. So there's not a lot of confusion afterwards, except they might realize that they've missed some time. And so they might ask you what you said. They might ask for a teacher to repeat something they said or require some re-teaching of material, because what happens in this one, although brief, oftentimes this type can cluster. So they might have 10, 15 of these a day. And even though it might be just 3 to 5 seconds, if it happens 10, 15 times a day, you know that they are missing little pieces of their day then, and it can interrupt their normal routine. So I'm going to show you this video. The response for this type of seizure is pretty simple. It's generally, again, that reassurance, making sure they know everything's okay, that they're all right, and then documentation, what you're seeing. Typically, if these have been under control through a medication or another treatment option, they start having them again, this is something that they're going to want to talk to their doctor about to see if they need adjustments to their treatment options. So we're going to go ahead and watch this girl. I'm going to show it to you twice again because it's pretty brief. So I'll just let you watch the first time, and the second time I'll talk about what you saw.
This girl has absence seizures, and you will see her have one while she's talking.
Because he can be as heavy as ever.
And there's a real blankness, a vacant look in the eye, and then all of a sudden they're right back with you and able to engage.
So that was about a 5-second seizure, I believe. And so what I want you to do the second time is you watch how she's talking. She repeats herself and her eyes flutter, and then she stares to the left, I believe it is. And so just watch how brief that is. When she starts to look to the left, that's when the seizure starts, and it stops when she comes back to awareness. So let's give that one another watch.
This girl has absence seizures, and you will see her have one while she's talking.
Because he can be as heavy as ever.
And there's a real blankness, a vacant look in the eye, and then all of a sudden they're right back with you and able to engage.
Oh, pardon?
So really brief, but you can see that there's a loss of awareness and actually a loss of consciousness for a brief period of time, and then she comes right back. So that's called an absence seizure. That seizure oftentimes is diagnosed in childhood, and actually we know that in the absence seizure type, many times it's teachers or school staff that will recognize that there's something going on with the student because they see them consecutive hours in the day, and they're noticing, especially if they cluster. And so oftentimes we have teachers say, we noticed that behavior, we wrote it down, told the parents, and later the parents then, did get the diagnosis after seeing a doctor for their child of epilepsy. So we're going to move into the fourth type. This is the generalized tonic-clonic. It is, if you've ever seen this type of seizure, it probably left a lasting impression on you. It's not the most common type, but often it's the type that many people who think about epilepsy or seizures think of. It used to be, like I said, called the grand mal way back, and it involves the complete loss of consciousness, loss of all control, could be bladder and bowel function as well. And it starts with there will be like a hoarse cry that happens, or a sudden cry out as the person becomes unconscious. They'll typically fall, whether it's falling over or falling right to the ground. They'll become stiff or tonic, and then they'll begin to shake or convulse, and that's the clonic phase of it. At times it might seem like they're not breathing, because they might hold their breath briefly. There might be a blue tint to their lips, their cheeks, their fingernail beds, things like that. As long as you can tell that they're breathing in some pattern, that's typically normal. So those are the things that is a typical pattern. They'll go through that full seizure, and you'll know it's done when their body goes completely limp. It's typically 1 to 3 minutes. We do know that at 5 minutes is when we want to make sure medical 911 is called, because they will need extra medical attention. We'll talk more about that in just a minute, but I'm going to go ahead, and we are going to watch a clip of a child having a tonic-clonic seizure. This little girl is laying on the couch on her side, and I don't know if she's waking up from a nap or what, but what I want you to do, besides observing the stiffening and the convulsing, is what other things are you noticing are happening with her body and then with the responder. We're just going to watch this one once, and we'll talk through it afterwards.
They affect the whole brain and the entire body. The tonic phase is the stiffening of the muscles. Then the jerking movements begin, the clonic activity that you see here. A tonic-clonic seizure rarely lasts more than a few minutes. A person having one isn't conscious and won't remember what happened. The skin may become pale. Breathing may seem shallow or labored. Sometimes a child may lose bladder or bowel control or vomit as the seizure ends. These seizures may look painful or even life-threatening.
That was about a 33, I think, second seizure. So it wasn't quite a minute, but a lot of things happening during that seizure, right? So she became stiff and she began to convulse. Things that I'd like to point out, because I think they're very typical in this type of seizure, and if you know what is happening, it can make responding to it a little bit, put you at ease a little bit more. So first of all, eyes. Her eyes got really wide. Typically, their eyes stay open, or their eyes might roll a little bit towards the back of their head. That is a very typical response. And so sometimes that can look like they're looking right at you, and really it's just the involvement of their eyes at that point. You heard sound probably, and so there's always a sound that comes with seizures, because the person doesn't lose their voice. So in this case, the sound really is in relationship to how her body's moving and how her convulsions are happening. A lot of drool. You might notice that they kind of zoomed in on that. That has, because your body just would produce a lot of extra saliva during this time. And so there's a lot of drool, and sometimes it comes out looking almost like bubbles because of how fast it's coming out and the convulsions that are happening. So you could tell that she went through her seizure. At the end, she had a few more pronounced jerking motions, but you could see when it was kind of a letdown of her breath and her body relaxed, that's when the seizure started, or excuse me, stopped. As far as the person responding, they just kind of rubbed her leg, and we're going to talk through response next, but it's perfectly fine to talk to the individual. Will they hear and remember? Probably not, because they have lost consciousness. And for many people, I would say the majority of people with this type of seizure, they don't remember what happened during the seizure. And during the seizure, they're not experiencing the pain. It's not to say they won't have discomfort afterwards and like a headache or muscle aches, but during the seizure, they do not typically know what's happening or feel that pain. So when we move into what we call our basic steps for response for generalized tonic-clonic, there's some key things you want to make sure we're doing. You want to get the individual on their side. She happened to be on her side, but you get them on their side in order to allow that saliva to flow freely. They might vomit at some point during the seizure, and you want that to be able to flow freely so they don't choke. You also get them on their side to help their tongue fall kind of to the side. If they are flat on their back having a seizure, there's a chance that their tongue could block their airway. It's not about swallowing your tongue, it's just about that potential for blocking the airway. So getting them on their side will allow for their tongue to kind of fall to the side as well. You want to cushion their head if possible. So anything softer than the ground underneath their head, because headaches can be one of the big side effects of having a seizure. You want to make sure you're protecting their head as much as you can. Removing any clothing or pushing things out of the way. Clothing that is tight or restricting, so thinking of glasses, thinking of button-up shirts, might have to loosen that top button. Giving them the proper space they need for their body to go through the seizure, and moving things out of the way and other people out of the way. You want to, again, of course, timing the seizure is key for this type as well. From the time the seizure starts until the jerking or the convulsing stops, that's the time frame that you're looking at. And really, when it hits the mark of like 5 minutes or whatever is considered, the mark for them where they're going to need extra assistance, then you want to be timing it to be accurate for those reasons. And then you want to, of course, stay with them. Many times a person, after the seizure stops, they go into like a recovery mode, and it takes some time to fully come back to awareness, to be able to sit up, talk, walk, and just function regularly. And so know that somebody should stay with them for that whole time. And at times they might need to actually get cleaned up, especially if they've lost their bowel or bladder functions or they vomited. And so it's key to keep someone there with them. We're going to move into talking about specific situations you might experience with students that have epilepsy. One of the specific situations is if a student or an adult is in a wheelchair. How do you handle that situation if they have this generalized tonic-clonic seizure in the wheelchair? You don't have to remove them. Actually, it's recommended that you don't remove them unless it's absolutely necessary. Depending on the wheelchair type and the function it serves, as far as if it gives them support and structure for sitting upright, that can provide more support than you taking them out and getting them on their side. It is hard to move a person onto their side having a seizure, much less trying to get them out of something like a wheelchair, down onto the ground and then onto the side. You want to reduce the risk for injury for yourself and for them. You want to secure the wheelchair, so put the brakes on. You can loosen that seat belt or any restraints that they have, just to give them more room for their body to move during the seizure. And you want to support their head. And so if they do not have head supports on their wheelchair, you can put a sweatshirt on either side of their head. You can maybe help support their head by turning it to one side so that saliva can drain. Don't hold it and restrain it, but you can protect and support it in several different ways. So that is wheelchair. Additional information about responding to someone in a wheelchair. Now let's get to the big reason you're probably here as a bus driver or transportation aide. How do you respond on a bus? A couple of things to note for buses. Obviously, you want to safely pull over and stop the bus. If you are the only one on the bus and there's no additional transportation aides, paraprofessionals, what you want to do is pull over. And you want to first and foremost follow the guidelines of your district. Is your procedure and your policy pull over, call back to dispatch? Is it to call 911 immediately? And whatever your process is, go through that process. But as you get to having to respond, getting to the individual having the seizure, what you want to do is place them on their side, using the seat, if it's in a regular bus with a regular seat, getting anybody else out of that seat, using the back of the seat as their sort of support, and getting them on their side is a good thing to do, because what it does is you can see their face, you can see that they're breathing, but you're also providing that support for them along the back of the bus seat. What do you do with the rest of the kids that are in the bus? You want them to move away from the student that's having the seizure, move them back and out of the way. Speaking calmly to them, letting them know that you are taking care of the situation, that the student will be all right. Because if they don't know what's happening, it can be very, very frightening for them. And yet just simply saying, they're having a medical issue and I'm going to help take care of them, and we're going to get this taken care of and then proceed on our route. So those are kinds of things you can say to the other students on the bus. Keeping in mind that, again, you want to follow whatever your seizure protocol is for your school district or your company. If you are a contracted service, is it to call 911 immediately? You follow your process that is put forth in front of you for your protocol, and then proceed to the steps as you normally would. The other thing is, if it is to call 911 and they get there and they then take the child then into the ambulance, then you would proceed to your route. Sometimes it's to go back to your starting point, and so just make sure you're aware of what you should be doing per your protocol for your school district. Times when you should call 911. So we talked about if it's in your protocol for your school district. We also talked about if it's 5 minutes or longer, that's called status epilepticus. Big fancy term, meaning it's a status situation of a seizure. But there are other times when a seizure happens where you should call 911. The first and foremost is if this is the first time someone's had a seizure, or you are not aware that they have epilepsy, or that they have ever had a seizure before, you treat it as if it is a first time seizure, and you call 911, because there could be something else going on medically that they need that medical attention. Injury, obviously, things like blood, things look like they've broken their arm going down into a seizure, things like that, obviously. If you cannot see that they're breathing, and so they begin to stiffen and they maybe hold their breath for a few seconds, and as they begin to convulse, you cannot find a breathing pattern, obviously that's an emergency, calling 911. If it takes place in water, as bus drivers, this is more than likely not going to happen, but in any other place in your life, if you see someone start to have a seizure in water, immediately remove them from the water, get them on their side, and call 911. Because there are things like water in their lungs and aspirating that we do not want to mess with as far as needing the medical attention and getting them there right away. Health conditions besides epilepsy that have seizures as a part of them. There are health conditions like diabetes where a person's blood sugar can become out of control and they might go into a seizure. It would look like a generalized tonic-clonic seizure, but that's related to their blood sugar, so you want to call 911 for that. Another health condition that we know you should call 911 for is pregnancy. So if a woman is pregnant and has a seizure, it's important to call immediately for that. And then, of course, if you have learned all of this information and you feel like in your gut something is not going to end well or go well in how you're responding, and you don't feel like you can fully handle the situation, you want to, of course, call 911. In the last 10 minutes here, we're going to go through some safety and some medication and treatment options, including medication and surgeries. And we're going to go through this period more quickly. So as we go through these, if you have questions, this would be a good time to jot questions down, give those to your supervisor who can then relay them to the Epilepsy Foundation, and we can then answer those questions back to them via email or phone call. Many times students who have epilepsy will have what we call a seizure response or a seizure action plan. So this typically happens at the beginning of the school year. If they have epilepsy, they bring in, they fill out their medical forms, all the forms that the school needs to have for them to start school. One of them could be a seizure action plan, and that action plan is really key for that individual's epilepsy. And so if you know you have a student that rides your bus that has epilepsy, Ask if there's a seizure action plan that you should be aware of as their bus driver. In particular, if you're the only one on the bus, that's the adult on the bus, right? So what should I have that on file so that if they have a seizure, I can quickly look at their response plan or their action plan and see this is typical. This is what it typically looks like. This is what how long I wait before I call 911 or give a rescue med. So seizure action plans can be very key for students and adults alike, but in school settings, in students, it's a great piece of documentation that helps everyone. We do know that there are certain things that we like to recommend as far as water, swimming with a buddy, as far as fire safety, no open flames or open fireplaces, or not to be around those without another person near. And just safety proofing things in your home environment. There are many seizure alert monitors that we know of that actually help with detecting seizures and then sending alerts to caregivers and the like so that they can be aware that a seizure is happening and respond appropriately. And there are also driving laws for each state in the United States about driving with epilepsy. And in the state of Minnesota, you can hold a license, and if you have a seizure, it's a self-reporting state where you are required to report that. And if you have a seizure, then what needs to happen is you report that yourself, and then there's a 3-month suspension of your license for you to get control through, whether it's new treatment option, and then to report back that you are for the doctor to give you a note that says, yes, I have seizure control and I can safely drive again. SUDEP is, we talked briefly that it's rare to die from having epilepsy or a seizure, but there is something called sudden unexpected death in epilepsy, and there are risk factors for those who have epilepsy if they have uncontrolled seizures, if they take multiple medications, if they've had epilepsy for a long time, if they have nocturnal or nighttime seizures. There's much information in the research area about SUDEP, and a lot of work being done to try and figure out why is this happening, because there is not a pinpointed reason for SUDEP to occur. So the National Epilepsy Foundation, which we are an affiliate of, has a whole institute called the SUDEP Institute. So if you're interested in learning more, the website is listed here. I'm going to briefly, and by briefly, I do mean briefly, run you through some treatment options. Because as in your role as a bus driver, you might need to know a little bit about treatment options and a couple in specific that might require you to have some response. And then we'll wrap it up with some information about EFMN. So the main treatment option for most conditions in the country or in the world is medication. It's not any different for epilepsy. So the first line of treatment is medication. And we know that when a person tries medication, about 70% of the people with epilepsy will get seizure control. Doesn't mean the first medication, but it means through medication trials, 70% of our clients that have epilepsy, or the population that has epilepsy, will get control through seizure medication. There's over 30 seizure medication, anti-seizure medications. There's ones that are actually FDA approved every year, and so that list is continually changing. And as a non-health professional, if you have questions specific, honestly, to medications, that is something that I would refer you to a medical professional or doctor or a nurse. One thing about medications, though, to note is that for rescue medications, there are those who have seizures that they know in their diagnosis through their experience that they're going to have harder to control seizures. And so they might have what we call a seizure rescue med. And what that means, the medication that is prescribed to them can be given by a lay person or a non-medical person in the event that a seizure starts and it goes a certain period of time as identified in their seizure action plan. And it should be given according to those instructions from the medical professional. Oftentimes what we know is that in school settings, there's not the entire school staff is not trained on how to administer these, but a select number of people who interact the most with that student might be trained as to how to administer. You might be that person as the bus driver, especially, or if you're the transportation aide or the paraprofessional that's with them on the bus, you typically would be trained separately on how to administer them. There's lots of ways that they can be administered. There's a rectal suppository, there's a buccal nasal, or excuse me, a buccal drop in the mouth, and a nasal spray. They're all the same sort of medication, but what they do is they slow the brain down to try and stop the seizure. Up until recently, the Diastat rectal suppository was and continues to be the most commonly prescribed because of its efficacy and its known efficacy and how long it's been on the market. But recently, there is a newer rescue medication that was FDA approved that is a nasal spray. And so what we know is that more and more doctors are looking at that as an option for rescue med as opposed to the rectal suppository. The one downside of any new treatment is that the cost can be a factor for individuals. If it's a brand name and there's something else that will work the same, sometimes we see insurance companies not covering, or the individual having to pay a higher copay for newer medications. So just know that there are different rescue medications. Two common ones are nasal spray and a rectal suppository. And if you are the only one on the bus, or you are assigned to that student on the bus as their paraprofessional, you would be trained separately how to administer these. There are brain surgery options for those who have epilepsy, but not for everyone. It typically is in those who have focal seizures, those focal aware or focal impaired aware. And typically they're done after a couple of trials of medications that fail. If you have generalized epilepsy, brain surgery options are much more limited, because one of the main ways that brain surgery is used is to remove that portion of the brain where the seizures are coming from. And so in a focal seizure, that's more succinct and easier to do. Than you couldn't do that if you had generalized seizures. There's also diets. So the ketogenic diet, which many of us know all about because it's a fad diet right now for the general public, was actually developed by a man in response to trying to figure out how to help someone with intractable seizures. Our standard American diet has about 60% carbs, 25% fat, and 15% protein. But when we look at the keto diet, it's about 90% fat, 8% protein, and 2% carbs. And so it is a very, very high fat diet, and it keeps the body in ketosis, which for those who have intractable epilepsy, some of those, it is actually successful in helping control their seizures. Finally, there are 3 different medical device implants currently. There's an RNS, a DBS, and a vagal nerve stimulator, or a VNS. And I'm going to pause and talk about the vagal nerve stimulator for a moment, because it's the oldest one and it is approved for those over the age of 4. So you might have students who have a vagal nerve stimulator. How would you know? It would be in their seizure action plan, but you would also see that they have this pulse generator, or it's an incision generally in the left side of their chest, where it's a pacemaker device that's implanted with wires run up to their vagal nerve, and those wires are wrapped around, and it sends a regular electrical impulse to their brain to keep their brain sort of in that regular pattern of electrical activity. If the individual goes into a seizure, they carry on them a magnet. It might be on their wrist, it might be on their belt buckle, and you would take that in response, you would take that magnet, swipe it over the site of the device on their chest, and it turns it on at double strength to try and bring them out of that seizure, or to try and shorten the seizure, shorten the recovery period, or the intensity of it. So that's where it might be where you would have some involvement with responding if there's a vagal nerve stimulator. We do know that medical cannabis is a hot topic for lots of different disorders. We have one FDA-approved drug that has medical cannabis basis, and that's called Epidiolex. And it is FDA-approved for very specific, very hard-to-control epilepsy syndromes in young children. Right now, we know, though, that the Minnesota statute does not allow any form of cannabis products to be given on school grounds or in buses. So you would not be required or should not be giving any of those kinds of medications. Finally, to wrap us up here, I just want to talk through that one thing we do know is that, like I said, 50 to 60% of the population with epilepsy will also have a mental health condition that can occur after their diagnosis. It could be related to the side effects of their meds. It could be related to where their seizures are coming from in their brain, or it could be just their perceived or real impact on their life. And so we do a lot of work to help provide those resources for mental health supports and things like that. We do know that seizure assistance dogs are more and more being trained and being utilized by individuals with epilepsy. And so you might have a student at some point along your journey as a bus driver who has an assistance dog. That dog would have a vest that would specifically say that they are a working animal, a working assistance dog, and they typically are trained to respond. It could be that they carry the emergency med on their backpack. It could be that they alert an individual to a seizure happening, so someone else that's on the bus or someone else that's in the area. It might be that if they have the vagal nerve stimulator, they carry that magnet and swipe that magnet. Dogs have been taught to do that as well. So you may see that in your workings as a bus driver. One thing I want to point out is we do have a seizure first aid app that's free, aid with an E at the end. This is a great app just for some basic things. It walks you again through first aid. It also has a timer on it, whereas the large button, the very first thing it says, it'll say when you open it is would you like to start the timer? So sometimes that can be really helpful if you are the only one responding. It does also show you some other videos of different other seizure types. Plus, it just has lots of information for you on that. So I encourage you to take a peek at that and use it if it will work for you. And finally, in concluding, I want to thank you for joining us for this Seizure Smart training. My name is Amy Haugen. I'm the Regional Program Manager, and my contact information is here. What I do want to say is efmn.org is our website. There's lots of information there. And know that we are here to offer education, support, answer questions. We have information services, which is truly just that. You can submit a web form or call our information services line and ask questions related to epilepsy and have us give you the relevant information if you're looking for some more in-depth information. With that, I'm going to pause and thank you once again for joining us. And if you have any questions, please feel free to reach out to the Epilepsy Foundation of Minnesota at efmn.org.